Good morning, everyone. Today we'll be discussing ventricular septal defect. Congenital heart disease is broadly classified into cyanotic and acyanotic. Acyanotic congenital heart diseases are further classified into left to right shunts and obstructive lesions. The left to right shunts are VST, AST, and PDA. We'll be discussing VST today. It is the most common congenital cardiac lesion. VSTs were first clinically described by Roger in 1879. VST may be an isolated defect or it may be part of a complex malformation. The incidence of VST is approximately 2 per 1,000 live births. Males and females are affected equally. As I said, VST could be part of complex heart disease. It could be associated with other congenital cardiac anomalies. So common associations are coarctation of aorta, AST, PDA, intracardiac obstruction such as subpulmonary or subaortic stenosis, mitral stenosis, incompetent atrioventricular valves. So if there is a VST, we should also make sure that none of these other lesions are there. Coming to the interventricular septum, it has a small membranous portion and a large muscular portion. The large muscular portion is further divided into inlet septum, outlet septum, and trabecular septum. Now, based on the site of the defect, VSTs can be classified into perimembranous. In this diagram, A, B, and C are perimembranous defects. A perimembranous defect is actually a defect in the membranous septum which extends into the muscular septum. And 70% of VSTs are perimembranous. Then inlet muscular VST, that is in this picture, D is inlet muscular VST, trabecular muscular VST, that is E, and F is infundibular or outlet muscular VST. Infundibular VST is also called subpulmonic or supracrustal VST. There is something called Swiss cheese VST. That is, it is a type of multiple muscular defect. There are multiple defects in this kind of VST, and the defects will be there in different parts of the septum. So it looks like Swiss cheese. The importance of Swiss cheese VST is that it is difficult to close surgically. Now there is something called Gerbody defect. Gerbody defect is a defect in the atrioventricular septum between the attachment of the mitral valve and the tricuspid valve, so that it leads to a shunt from the left ventricle to the right atrium. This is uncommon, but the importance of a Gerbody defect is that though it is a small defect usually, it can result in congestive cardiac failure. Usually small VSTs will not cause congestive cardiac failure. But in a Gerbody defect, because of the large volume of blood going directly into the right atrium, it can result in CCF. Now coming to classification based on size, small VST is defect. The size of the defect is less than 1/3 of the size of the aortic root. Moderate VST, the size of the defect is less than 1/2 of the aortic root. That is more than 1/3, but less than 1/2 of the size of the aortic root. And large VST is defect equal to or larger than the size of the aortic root. Then coming to classification based on shunt size. QP by QS, there is something called QP by QS ratio. That is the ratio of the pulmonary blood flow to the systemic blood flow. So a VST will be called a restrictive VST if the QP by QS is less than or equal to 1.4:1. Moderately restrictive VST is QP by QS more than 1.5 but less than 2.2:1. Non-restrictive VSTs are QP by QS more than 2.2:1. Now, coming to the hemodynamics. So there is a defect in the interventricular septum between the RV and the LV. So the blood shunts from the LV to the RV, and this blood enters the pulmonary artery, causing increased pulmonary plethora. The increased pulmonary blood flow returns to the left atrium, and from there across the mitral valve, it reaches the left ventricle. So here there is enlargement of the pulmonary artery, the LV and the LA. So in VST, there is shunting of blood from the left to the right ventricle. And in a VST with a moderate shunt, the shunting of blood is occurring during systole at a time when the shunting of blood from the LV to the RV is occurring during systole at a time when the RV is also contracting, so that its volume is decreasing. So there is no volume overload of the RV. It is as though the blood is shunting directly from the LV to the pulmonary artery, leading to enlargement of the pulmonary artery. The increased blood in the pulmonary artery returns to the left atrium, and from there to the left ventricle. So in a VST with moderate shunt, there is enlargement of PA, LA and LV without enlargement of RV. In large VST, there is direct transmission of LV pressure to the large defect to RV, in addition to the much greater shunt. So RV also becomes enlarged, leading to biventricular enlargement. In VST, the shunting of blood from the LV to the RV begins early in systole. So the murmur also begins early, masking S1. Towards the end of systole, the left ventricular pressure falls below the aortic pressure, so that the aortic valve closes, causing A2. But at this time, the left ventricular pressure is still higher than the RV pressure, so the shunt across the ventricular septal defect continues. So the murmur also continues. And murmur continues at a time when the aortic valve has already closed. So the murmur masks S2 also. And it is a murmur of uniform intensity as the shunt is occurring throughout systole. So we hear a PSM at the lower left sternal border, which masks both S1 and S2. The large volume of blood passing through a normal mitral valve results in a delayed diastolic murmur at the apex. The intensity and duration of the delayed diastolic murmur at the apex is directly related to the size of the shunt. In VST, the left ventricle has two outlets, one through the septal defect and the other through the to the aorta. So it empties early. As it empties early, the aortic valve also closes early, and so the A2 is early. But at the same time, the RV is receiving increased blood from the LV. So P2 is delayed. So in VST, A2 is early and P2 is delayed. So S2 is widely split, but it varies with respiration, unlike in AST, in patients with large VST. Coming to the clinical features, children with small VST may be asymptomatic. They are usually asymptomatic and have normal growth. Babies with moderate to large VSTs are symptomatic, and they become symptomatic around 6 to 10 weeks of age. This is because at birth, the pulmonary vascular resistance is very high. It is equal to the systemic vascular resistance, and it falls gradually as a child grows, and it becomes less than the systemic vascular resistance only by 6 to 10 weeks of age. So it is only by 6 to 10 weeks of age that a significant shunt develops from the left ventricle to the right ventricle. And only when a significant shunt develops, there will be clinical features of VST. CCF and other features only will develop by that time. Now, the main clinical features are congestive cardiac failure, then recurrent respiratory infections, and failure to thrive. Now coming to congestive cardiac failure, it may present with poor weight gain. Poor weight gain may be a feature of congestive cardiac failure. Then difficulty in feeding, which is called suck-rest-suck cycle. That is, the child sucks for some time. Then because of the effort of sucking is like exercise. So the child becomes dyspneic. When the child becomes dyspneic, the child stops feeding and takes rest. The child is still hungry. He has not had enough milk. So he sucks again. And the cycle repeats. This is called suck-rest-suck cycle. So you should be able to elicit this history of suck-rest-suck cycle. Then fast breathing. And the characteristic of this fast breathing is that the child breathes better when held against the shoulder. That is orthopnea equivalent in the older child. Then persistent cough and wheezing, irritability, excessive head sweating. Excessive head sweating is the result of sympathetic stimulation, which is a reflex response to congestive cardiac failure. Then pedal edema. Then recurrent respiratory infections. That's a very common feature of we all left to right shunts. That is because there is increased pulmonary blood flow that leads to congestion in the lungs. And so it will result in recurrent respiratory infection. So any child with recurrent respiratory infection, you should rule out congenital left to right shunt lesions. Then failure to thrive. There are many reasons for a child with VST developing failure to thrive. One is the infant takes small feeds because of easy fatigability. Then there is excessive loss of calories from increased work of breathing. Then recurrent pneumonia can result in failure to thrive. Then if VST is part of a syndrome or a chromosomal anomaly, then that syndrome, many syndromes are associated with failure to thrive. So because of that syndromic status, that can itself result in failure to thrive. Coming to the examination finding, the precordium is hyperkinetic with a systolic thrill at the left sternal border. In moderate and large VSTs, there will be cardiomegaly with LV type of apex. There will be a pansystolic murmur at the lower left sternal border, and S1 and S2 are masked by the pansystolic murmur at the lower left sternal border. S2 can be made out at the second interspace. S2 shows wide and variable split. That is in large VSTs. And in a large VST, S3 may also be audible at apex. Again, in moderate and large VSTs, a delayed diastolic murmur is audible at the apex. All these are features of moderate to large VST. A small VST, the precordium may be silent. There will be no cardiomegaly. There will only be a pansystolic murmur masking S1 and S2. There will be no MDM, no split, no S3. Now, based upon the clinical findings, you can assess the severity of VST. That is, you can say whether it is a small or a moderate or a large VST. In a small VST, there is no cardiomegaly, no mid-diastolic murmur, and S2 is split normally. In a moderate VST, there will be cardiomegaly, but no mid-diastolic murmur, and S2 is split normally. Large VST, there will be hyperkinetic precordium, cardiomegaly, mid-diastolic murmur. S2 will show wide and variable split. Now, pulmonary hypertension is a complication of large VSTs. So, the patients of VST may have either obstructive or hyperkinetic pulmonary hypertension. That is, initially the patient develops hyperkinetic pulmonary hypertension, which later goes in for obstructive type. Hyperkinetic is when there is increased pulmonary, it is because of the increased pulmonary blood flow. Obstructive means structural changes will occur in the pulmonary vasculature because of the increased pulmonary blood flow. In both, P2 is accentuated. In hyperkinetic PAH, cardiac impulse is hyperkinetic with PSM and thrill. S2 has wide variable split with accentuated P2 and mitral mid-diastolic murmur. In obstructive pulmonary artery hypertension, there will be a forcible left parasternal impulse because of right ventricular hypertrophy. Systolic murmur is ejection type. Thrill is absent. S2 is normally split with accentuated P2, and there is no mitral murmur. Coming to the natural history of VSD, patients with VSD have a variable course. Patients with a small VSD may remain asymptomatic. 70% of all ventricular defects become smaller in size. A smaller proportion will undergo spontaneous closure. About 60% of small to moderate muscular VSDs close spontaneously, but not after 8 years. As the age advances, the rate of closure decreases. About 35% of small perimembranous VSDs close spontaneously, but not after 5 years of age. Inlet and outlet defects do not become smaller or close spontaneously. Coming to the complications, CCF is a very common complication. Then others are pulmonary hypertension, aortic regurgitation, infective endocarditis, then infundibular pulmonary stenosis. So CCF develops in moderate and large VSDs. Then pulmonary vascular obstructive disease may begin to develop as early as 6 to 12 months of age in patients with large VSD. Then infundibular stenosis develops due to hypertrophy of the right ventricular infundibulum. This is called Gessul phenomenon. This is seen in infants with large defects usually. Then aortic regurgitation can occur due to prolapse of the right coronary cusp of the aortic valve. VSD is the commonest congenital lesion complicated by infective endocarditis. So this is the natural history, the changes that can occur in a VSD. Coming to the investigations, ECG. With a small VSD, ECG is normal. The moderate VSD, left ventricular hypertrophy is seen. With large VSD, ECG will show features of biventricular hypertrophy. If pulmonary vascular obstructive disease develops, ECG will show right ventricular hypertrophy. Coming to the chest X-ray, in a small VSD, chest X-ray will be normal. There will be no cardiomegaly, there will be no pulmonary vascular changes. In moderate to large VSDs, there will be cardiomegaly involving the left atrium, the left ventricle, and sometimes the right ventricle. Right ventricular enlargement is usually seen in large VSDs. Then prominent main pulmonary artery shadow is seen because there is pulmonary artery enlargement. Then branch pulmonary arteries are also dilated. Then increased pulmonary vascularity extending to the lateral 1/3 of the lung fields is seen. In pulmonary vascular obstructive disease, the main pulmonary artery and the branch pulmonary arteries enlarge, but the peripheral lung fields are ischemic. That is, there is decreased vascularity in the peripheral lung fields. This is called peripheral pruning, and the heart size is normal. So this is the X-ray of a child with large VSD and without pulmonary hypertension. So there is cardiomegaly. You can see the main pulmonary artery is enlarged. Main pulmonary artery is enlarged. Then you can see that the branch pulmonary arteries are also enlarged. And you can see there is increased vascularity extending up to the lateral 1/3. The peripheral vessels can be seen. Prominent peripheral vessels can be seen. This is the X-ray of a child with pulmonary hypertension. Here there is no cardiomegaly. The pulmonary main pulmonary artery is prominent, and the branch pulmonary arteries are also enlarged. But in the periphery, there is no increased vascularity. The periphery is ischemic. So this is the X-ray of pulmonary hypertension. Now coming to echocardiogram. Echo shows increased left atrial and ventricular size as well as exaggerated mitral valve motion. 2D echo can identify the number, the site, and the size of the defect, and the presence or absence of complications like pulmonary stenosis or pulmonary hypertension, and other associated defects like I mentioned before, coarctation of aorta, mitral stenosis, etc. Coming to cardiac catheterization, that is required only in rare patients to decide when it becomes difficult to decide whether the child is having pulmonary hypertension. That is, pulmonary hypertension is a contraindication to surgery. So before surgery, in some cases, cardiac catheterization may be required. That is in borderline cases where a definite decision cannot be made regarding operability after a good history, examination, and non-invasive investigations like X-ray, ECG, and echo. So before to decide whether surgery can be done. For that, in a few patients, cardiac catheterization may be required. Then device closure is one option for closure of VSD. So if we are going in for device closure, then for the purpose of device closure, transcatheter closure, you can do catheterization. Right heart catheterization is considered the current gold standard to assess hemodynamic parameters and vasoreactivity in these patients. Then coming to the treatment, there is medical management and surgical management. Medical management is treatment of congestive cardiac failure. Consists of rest, oxygen inhalation, diuretics, digoxin, AC inhibitors. Then another thing that might require medical management is prophylaxis for infective endocarditis. Then coming to the surgical management, the all VSTs may not require closure. So if it is whether closure is required or not depends upon the size of the VST. So small VSTs with no symptoms, normal pulmonary artery pressure, normal left heart chambers, and no cusp prolapse, only annual follow-up may be required till 10 years of age. Then after 10 years, follow-up every 2 to 3 years. That is, the follow-up is to see whether the child is developing any complications. If there are complications, then the child may need surgery. Closure is indicated in a small VST if the patient has had an episode of infective endocarditis or develops cusp prolapse with aortic regurgitation or develops progressive significant right ventricular outflow tract obstruction. So only in these conditions, a small VST will require closure. Then moderate VST should be closed. So if it is asymptomatic, then closure of VST is done by 2 to 5 years of age. If it is symptomatic, if it is controlled and symptoms are controlled with medication, VST closure by 1 to 2 years of age. If symptoms are not controlled with medication, then immediate closure should be done. Large VST, if there is poor growth, CCF, not controlled with medications, as soon as possible. Then VST with aortic cusp prolapse. If any VST develops aortic cusp prolapse with AR is an indication for surgery. So whenever AR is detected, surgery should be done. Then contraindication for closure is severe pulmonary artery hypertension with irreversible pulmonary vascular occlusive disease. That is obstructive hypertension. Hyperkinetic pulmonary artery hypertension is not a contraindication. Obstructive pulmonary artery hypertension is a contraindication for closure. Then method of closure, it can be definitive surgery or palliative. Palliative procedures are usually done in very few cases. That is pulmonary artery banding. It consists of pulmonary artery banding. That is, the band is tied across the pulmonary artery to decrease the pulmonary blood flow. This is usually done in patients with multiple VSTs, that is Swiss cheese VSTs, inaccessible VSTs, in cases where surgery is difficult, or patients with contraindications for cardiopulmonary bypass. Then definitive treatment, it can be open surgery or it can be device closure. Open surgery, patch closure is a standard therapy in most patients. And device closure is a device is passed across the catheter and then the defect is closed. That is device closure. There are criteria for device closure, that is weight more than 8 kg, more than 5 kg for muscular VSCs. Then left to right shunt more than 1.5:1. Then contraindications for device closure are VSTs with irreversible pulmonary vascular disease, then pre-existing left bundle branch block or conduction abnormalities, then any aortic regurgitation, then associated lesions requiring surgery, then inlet and outlet VSTs. That is, or outlet VSTs are also called subpulmonic VSTs. So inlet and subpulmonic VSTs. So these are the contraindications for device closure. Thank you. Any doubts? No. Doubts ഒന്നും ചോദിക്കാൻ പറഞ്ഞു പക്ഷെ റെസ്പോൺസ് ഒന്നും